I'd say welcome to the Department of Medicine Grand Rounds here on March 22nd. We have a fantastic talk lined up for you today, one I'm very excited to hear. Our speaker today is Dr. Sara Turbow, MD, MPH. She's an associate professor of medicine and preventive medicine here at the School of Medicine. I feel like it was just not so long ago that you were a resident, Sara, but you are now an associate professor. Congratulations. She obtained her MD and MPH in epidemiology from Emory and completed her internal medicine, primary care, and preventive medicine residencies here at Emory. She is a health services and aging researcher focusing on inter-hospital care fragmentation. And she has an NIH Career Development K23 award to study risk factors for and potential solutions to care fragmentation in older adults with Alzheimer's disease and related dementias. She is also the associate program director for the School of Public Health and General Preventive Medicine residency program. So this is fantastic and very exciting, and you are going to talk to us about care fragmentation. So
yes,
why don't you go ahead and share your screen?
All right. All right. Thank you so much. I am just so excited to be here today to talk to you all about why you should care about care fragmentation. So I have received grant support from Merck in the past for research unrelated to this work. And as Dr. Armstrong mentioned, I'm currently supported by NIH, but the results I'm going to share with you all today are solely my responsibility and do not necessarily represent the official views of NIH. So in this talk, I'm going to provide kind of a state-of-the-art overview about research focusing on care fragmentation. And I'm going to highlight the work that I and others are doing to understand and begin to solve this challenge. I'm going to also weave in future directions and current challenges of this research throughout as well. So the learning objectives for today's talk are to recognize the impact of inter-hospital care fragmentation, to discuss 5 reasons that care fragmentation is important, and to identify potential systems-level solutions to care fragmentation. But first, what is care fragmentation? Care fragmentation can mean many different things to different people because there are just so many ways that care can be fragmented. Here are some broad categories that care can be fragmented between. So for example, care can be fragmented between clinicians. Think a PCP and a specialist, or a PCP and a hospitalist.
How you doing? Oh, I'm good. How you doing?
Care can also be fragmented between institutions. For example, between 2 hospitals or between a hospital and a nursing home. Finally, care can be fragmented between entities like social services, pharmacies, prison, or insurance companies. In this talk, I am primarily going to be talking about care that is fragmented between different hospitals, which is also called inter-hospital care fragmentation. Inter-hospital care fragmentation occurs when a patient is initially admitted to one hospital and then later readmitted to a different hospital, as illustrated here on the bottom. I'm going to use the terms fragmented readmission and inter-hospital care fragmentation interchangeably. So to put this in context of our local hospitals, a non-fragmented readmission would be an admission to EUH and a readmission to EUH, or an admission to Grady and a readmission to Grady. A fragmented readmission, while at its most basic is a readmission to any different hospital, it exists on a spectrum. So you can think about how an index admission to EUH and a readmission to EUHM would be considered fragmented, but it's different than an index admission to EUH and a readmission to Piedmont or the VA, for example. So my interest in care fragmentation, particularly inter-hospital care fragmentation, started when I was a resident here. Like Dr. Armstrong mentioned, I would see the same patients at Grady and UHM and like sometimes even at the VA. And it really made me wonder if anybody was tracking these patients or if people were studying how these admissions in different locations impacted them. However, the impact of fragmented care was really driven home for me when my family felt its effects. And so this is my paternal grandfather, who we called Pear, and he taught me that I can do anything I put my mind to, which he called having an arm of light. He lived an amazing, accomplished life, and he passed away in 2019 at the age of 92. While he had his health challenges over the years, the hospitalization during which he died was plagued by fragmented care and information discontinuity. Like many older adults, he was a snowbird, spending half the year in Virginia Beach and half the year in Florida. Unlike many, however, his healthcare wasn't limited to those places. He also saw a pulmonologist at NIH for many years. This setup led to challenges when he was hospitalized with pneumonia in Florida, and the care team there couldn't get his health records from Virginia Beach or NIH. And while we were able to eventually get his medical records to Florida and get the contact information for his other physicians, he unfortunately developed complications from pneumonia and hospitalization and passed away. I'll never know whether the Florida team having access to all of his health information would have changed the outcome of his hospitalization, but I do know that it shouldn't fall to families to resolve the structural barriers to the flow of information between settings of care. And I'd be willing to bet that every single person in this Zoom room has had experience with fragmented care, most likely as a clinician, but perhaps as a patient, a caregiver, or a healthcare leader. But if your personal or professional experience isn't enough to convince you that care fragmentation is important, I'm going to share with you 5 reasons why you should care about care fragmentation. The first reason is that it is common, and here are some statistics to back that up. The average US-based physician has to coordinate with 229 other care providers across their patient panel. Another study found that the average physician in an average size urban hospital was connected to 187 other doctors for every 100 Medicare patients on their panel. What about acute care though? So in an ongoing study, we found that on average, a pair of hospitals shares 439 patients. When we looked at this at the state level, we found some variability. And if you're curious, in Georgia, that number was 289 patients. While that might not seem like a very large number, think about what that means when a single hospital is part of dozens or even hundreds of pairs across a metropolitan area or a state. Another study looked at dispersion of patients across hospital networks, and they reported that hospitals share Medicare patients with a median of 31 other hospitals. The bottom line is that 20 to 25% of 30-day readmissions occur at a different hospital than the admission hospital, meaning that up to a quarter of all 30-day readmissions are fragmented. And although it's not going to be the focus of this talk, I want to just reinforce that fragmented care occurs beyond the clinic and the hospital. Think about public health and health system integration. We've really had a spotlight shined on how fragmented that relationship is during COVID. Think about other settings of care. You know, when you get a patient admitted from a nursing home or you discharge them to a nursing home, that care is very fragmented. And finally, pediatric to adult care transitions are another example of a very fragmented care transition. Reason number 2 that you should care about care fragmentation is that it is bad for patients. For this section, I'm going to narrow the focus to only interhospital care fragmentation, which again occurs when a patient is readmitted to a different hospital than they were previously discharged from. A few years ago, I had the pleasure of working with one of our internal medicine residents, Katie Snow, to do a systematic review of patient outcomes following fragmented readmissions. And mortality was the most common outcome that the studies we included looked at. We had 22 studies in the paper and 18 looked at mortality. For in-hospital mortality, the studies found an increase of 10 to 100% in the odds of dying during the readmission if the readmission was fragmented compared to a non-fragmented readmission. However, the study populations that these articles looked at were very heterogeneous, and I've included some examples on this slide. So you can see that they range from a nationally representative sample to patients readmitted after cancer surgery, to patients readmitted after having an initial admission that required ICU care with mechanical ventilation. And this heterogeneity really prevented us from doing any quantitative comparisons of these studies. And it's going to be kind of a theme throughout this talk that I'll discuss. But I do want to highlight that post-surgical patients are a real area of focus in this literature. And you can all imagine why. Surgeons are going to be very curious about what happens to their patients if they operate on them and then they have a later readmission to a different hospital. To me, this kind of raises the question, does fragmented care impact all patients the same? And I'll come back to try to answer that. We did a study using the 2014 National Readmissions Database, looking at whether the impact of a fragmented readmission differed by whether the patient was readmitted for the same or a different reason than their initial admission. In case you're not familiar with the National Readmissions Database, which is also called the NERD, it's one of AHRQ's databases, and it's a nationally representative sample of all non-federal discharges over the course of the year. And the way that we defined same or different readmission was using MDCs, or major diagnostic category, which is kind of the largest bucket of ICD codes. So overall, we found higher odds of dying during a fragmented readmission compared to a non-fragmented readmission, but that the odds of dying during the readmission didn't differ by whether the patient was readmitted for the same or a different reason than the index admission. However, when we looked at specific diagnoses, we did start to see some differences. So among patients whose initial admission was for CHF or COPD, being readmitted for a different reason carried much higher odds of mortality. However, that wasn't the case for patients whose initial admission was for an MI. And so again, this shows that fragmentation doesn't impact all patients the same. And I think that we need to develop a better understanding of which patients are at the highest risk for poor outcomes during and following fragmented readmissions. In our systematic review, several studies also looked at post-discharge mortality, and they found an increase in the odds of dying following the fragmented readmission. So the patient would have an initial admission, a fragmented readmission, and now we're talking about dying in the time period following that fragmented readmission, an increased odds of 10% to 3 times as much compared to patients with non-fragmented readmissions. Again, however, the patient populations were very heterogeneous. And in this case, the time periods that they looked at were also pretty diverse. So a number of studies looked at 30-day mortality, and those were more consistent in showing an association. A few studies looked at much longer time periods. I included one that looked at a year here, but we also had a study that looked at 7 years for post-discharge mortality, and those didn't find as strong of an association. But to me, this signals that, even if you survive your fragmented readmission, you could be at increased risk for mortality in the days to weeks following it. Part of my current work is examining the impact of fragmented readmissions on older adults. And I chose to focus my K23 on older adults, in particular, how fragmented readmissions might disproportionately affect older adults with Alzheimer's disease compared to those without, because I felt like this could be a population that might be disproportionately impacted by fragmented care. If you or I had a fragmented readmission, we'd be able to transmit our health history, our medications, we might be able to report what happened at the previous hospitalization. But if you have cognitive impairment, you're not going to be able to, as effectively transmit that information. And so, one of the things I'm really curious about is whether a fragmented readmission has an impact on discharge destination in this population. And so for this analysis, we use Medicare data for patients with index admissions for select hospital readmission reduction program conditions, as well as syncope, UTI, dehydration, and behavioral issues. And we included over 400,000 admission-readmission pairs. And so again, the outcome that we're looking at here is after your readmission, whether it's fragmented or not, where are you discharged to? And the 3 sort of locations I'm going to highlight are home with home health, hospice, or leaving AMA from the readmission. So for beneficiaries without Alzheimer's disease, we observed 11% lower odds of discharge home or discharge to hospice, 6% lower odds of discharge home with home health, but 50% increased odds of leaving AMA from the readmission. And this is all in fragmented readmissions compared to non-fragmented readmissions. And one of the major issues with fragmented readmissions is the fragmentation of information. If you don't have access to a patient's advanced directives or information about their baseline, that could impact your discharge planning and can have a negative impact on care coordination during the readmission. And that's my hypothesis for why we're seeing potentially these lower odds of discharge home with home health or to hospice, which could be favorable discharge outcomes in the right clinical setting. The increased risk of leaving AMA is very interesting to me, and it's something that we've seen in other studies. So this is the study we did where we looked at readmissions for the same or a different reason. And we also found that patients with fragmented readmissions were more than twice as likely to have left AMA from their initial admission. And we all know that leaving AMA is bad for patients. And I think that it tracks that patients who left AMA are more likely to have fragmented readmissions. If you're unhappy with the care you're getting, why not go somewhere else the next time you need care? And this touches on an incredibly important challenge with this research area, which is differentiating appropriate versus inappropriate fragmentation. Defining it and measuring it, especially in secondary data analyses, is really, really challenging. And there's a significant lack of qualitative studies around this. So I think that this is going to be a really interesting potential future direction for this field, to kind of tease out what is at the heart of this association between leaving AMA and fragmentation. In our systematic review, we also had 6 studies that looked at length of stay as an outcome. And again, one challenge was the heterogeneity with which they measured and compared length of stays. But about half of the studies found increased length of stay in fragmented readmissions compared to non-fragmented readmissions. And that ranged from about a quarter of a day to a day longer. In our study examining outcomes in fragmented readmissions for the same or a different reason as the index admission, we also found an increase of about a half a day longer length of stay in a fragmented readmission compared to a non-fragmented readmission. While this may not seem like much, again, we're talking about a quarter of all 30-day readmissions, and it really adds up. And then especially when hospitals are at capacity, like they are a lot of the time now, that quarter of a day or half a day can really be felt by the healthcare system and by the patient. Okay, reason number 3 that you should care about care fragmentation is that it is bad for the healthcare system. So the majority of research on care fragmentation is focused on the patient, how many hospitals or providers they access and what their outcomes are. And this is certainly important, but as a health services researcher, I'm also very interested in how fragmented care impacts the health system more broadly. So I'll focus on a few specific outcomes that I and others have investigated. The first is higher costs. So do fragmented readmissions cost more? And the answer is, from our systematic review, we're not really sure. So in the review, studies found the full range of outcomes. So ranging from fragmented readmissions actually being less expensive to there being no difference in the cost of a fragmented versus non-fragmented readmission, to an increase of about $300 to $1,000. Similarly, in our study where we looked at readmissions for the same or a different reason, we did find an increase of about $1,200 to $1,300 in the cost of a fragmented readmission compared to a non-fragmented readmission. One reason for potentially increased costs is low value care and waste, particularly repeat labs and imaging. So if you don't know what happened at the previous hospitalization, you might be more inclined to order labs, order tests if you don't have those results. This is an area of study that is more nascent in terms of the relationship between low value care and waste and fragmentation. But I think that it's going to lead to really exciting, actionable results. So this is a classic article by Berwick and Hackbarth from JAMA 10 years ago, which describes categories of US healthcare waste. And of the 6 categories described in the paper, fragmented care can impact 4 of them. So a patient with fragmented care may not get the care they need, which could lead to a failure of care delivery. That care may be delayed due to a failure of care coordination. Tests or imaging may be repeated, leading to overtreatment. And I don't have to tell you all that anytime care is shared between different providers or locations of care, additional administrative complexity is added. Duplicate radiology procedures are one area related to waste and low value care where the impact of fragmentation has been investigated. I want to highlight 2 example papers. The first looked at outpatient care fragmentation and found that patients with increased outpatient fragmentation had 2 times as many radiology and diagnostic tests as those who did not. Another paper looked at patients with strokes, and they compared geographic areas of the country with the highest amount of fragmentation to those with the lowest. And they found that patients with stroke in the geographic regions with the highest amount of fragmentation had 77% higher odds of having a repeat head CT than patients in the geographic areas with the lowest amount of care fragmentation. And we'll come back to duplicate radiology procedures in a little bit. Increased risk of readmission is probably the outcome that has one of the most consistent associations with fragmented readmissions. And so what we're talking about is an index admission, a readmission somewhere else. And so we're talking about the odds of a 3rd readmission. In our systematic review, the odds of a 3rd readmission were about 20% higher to 2 times as high in fragmented readmissions compared to non-fragmented readmissions. The next reason that you should care about care fragmentation is that it's an equity issue. I really like this framework for achieving health equity that was published by Siva Shankar et al. In NEJM Catalyst. Fragmentation hasn't really been viewed through a health equity or health disparities lens that frequently, but in my mind, it really is such an issue. So on this framework, fragmented care impacts level 1, access to care, level 2, transitions of care, and level 3, quality of care. And I also think if we consider care fragmentation as both a symptom and a cause of health disparities, it can help us come up with creative solutions, which we're going to talk about next. And our data shows that vulnerable patients are at risk for fragmented readmissions. So this is our paper where we compared fragmented readmissions for the same or a different reason. And we observed that most patients with fragmented readmissions were in the lowest zip code income quartile, and that patients with fragmented readmissions had much higher rates of reporting drug and alcohol use. And then in our paper examining discharge destination following a fragmented readmission among Medicare beneficiaries, the only group that was kind of overrepresented in non-fragmented readmissions were white patients. And again, we don't know if fragmented readmissions are one of many contributors to health disparities in these populations, or if patients who are historically marginalized by the healthcare system seek care elsewhere because of negative experiences or poor treatment. And I think that this is going to be an incredibly important kind of area of study within care fragmentation over the coming years. But I don't want this presentation to be a downer. So the final reason that you should care about care fragmentation is that it has solutions. A lot of my current K23 research is focused on these potential solutions to care fragmentation. Care fragmentation is probably not something that we're going to be able to eliminate completely, but I think that we already have some tools to mitigate it. And I'll start with a brief recent story about one such potential tool, and then I will dive into the data. So in early January, I was responding to medication refills while I was in clinic. And I was looking at a patient's chart to see when her meds had last been filled, if they were still indicated. And I noticed that she had been seen recently at an outside ED and had imaging of her spine that showed a sclerotic bone lesion. I poked around a little bit more and realized that this patient had a history of breast cancer and that this lesion hadn't been seen on any of her previous scans. This prompted me to get in touch with her care team, and she was able to see her radiation oncology NP shortly thereafter. So this patient had fragmented care between Grady and another hospital emergency department. Fortunately, thanks to a health information exchange and probably my own biases to go looking for these things and to, follow them through, the information from her ED visit was easily accessible to me and I could act on it. I really like this quote from the National Academy of Medicine: "Connected care is the goal, disconnected care is the reality." And I'll add, are HIEs part of the solution? So what are HIEs? So health information exchanges, which are defined as electronic systems that share health information, as well as shared electronic health records, are one potential solution to the information discontinuity that is present in fragmented care. I and many others hypothesize that a major reason for the negative patient and health system outcomes that we observe following fragmented care is due to a lack of information about what happened at previous admissions or at outside offices, and HIEs can bridge this gap. My current work is focused on the association between information sharing via HIEs or shared EHRs and patient outcomes, specifically mortality, duplicate imaging, and discharge destination among older adults. And so this is how I've conceptualized the different types of information sharing that may exist in fragmented and non-fragmented readmissions. So first up, we have our friend, the non-fragmented readmission. Patient is initially admitted to one hospital and readmitted to the same hospital. If you think about what that means for accessing the information from the first admission, it should be all there, right? The notes, the discharge medication list, the plan of care, everything should be readily available to the care team during the readmission. Next up, we have a fragmented readmission to a hospital in the same healthcare system. So think an index admission to EUH and a readmission to EUHM, for example. The readmission is fragmented, but there is an easy way to still get that information from the index admission. In Emory's case, there's a shared EHR and the information is readily available. Next up, we have a fragmented readmission to a different hospital outside of the healthcare system in which HIE is available. So this would be, for example, an index admission to Grady and a readmission to Piedmont. Both of them use Epic. Epic has an HIE that allows you to access information. However, not all HIEs are as user-friendly, and some even require you to have a separate logon, adding multiple additional clicks to your workflow. So the information may be available, but it may not be easy to access, and it might not be complete in this situation. And I know I used the Grady and Piedmont example, but I am looking forward to being able to use Emory and Grady as an example later this year when Emory gets Epic. And finally, a fragmented readmission in which no information is shared. So this would be a readmission to a different hospital in which one or both hospitals do not participate in HIE. So there's no means of electronic information sharing between these two entities. All right, so these are the results from the study of discharge destination following a fragmented readmission in Medicare beneficiaries that I showed you previously. So again, just as a reminder, we found that a fragmented readmission compared to a non-fragmented readmission was associated with lower odds of discharge to hospice and home with home health and higher odds of discharge against medical advice or of the patient leaving AMA. However, when we limited the analysis to only fragmented readmissions and we compared fragmented readmissions in which there was a means of electronic information exchange, so either a same system readmission with shared EHR or an out of system readmission with HIE available at both hospitals, and compared those to a fragmented readmission in which there was no means of information exchange. We found very different results. We found 7% higher odds of discharge to hospice and 16% higher odds of discharge home with home health. And so what this suggests to me is that these systems of electronic information exchange can facilitate care coordination and might mitigate some of that information discontinuity that was present in fragmented readmissions. So again, these are all fragmented readmissions. We're just splitting them up by whether there's a means of electronic information exchange or no means of electronic information exchange. However, the same was not seen for patients leaving AMA. So again, when we compared fragmented readmissions with electronic information exchange to those without, we actually didn't see a difference in the odds of leaving AMA from the readmission. And I think that that might be because leaving AMA might be less sensitive to care coordination. And so, the ability to access information from the previous admission might just have less of an impact on the reasons that people leave against medical advice. This is another ongoing study looking at the odds of repeat imaging on the same body system category. So in case you're not familiar with how ICD-10 codes radiology procedures, they have 31 different body systems, which we collapsed into 7 body system categories. These are pretty big categories. So we're talking head, chest, abdomen, etc. And for this study, we were agnostic to imaging type. And so what we found was actually, we found no difference in the odds of duplicate imaging in Medicare beneficiaries with Alzheimer's disease when there was electronic information exchange present or when they had non-fragmented readmissions. And we actually found increased odds of repeat imaging for beneficiaries without Alzheimer's disease when there was information exchange available. This is not what we hypothesized, but it is actually in line with some previous studies, one of which found a 25% increased odds of providers ordering repeat imaging when they had access to previous imaging results. But all is not lost. In the American Hospital Association Information Technology Supplement, which is the data source that we use to identify HIE participation by hospitals, they also ask questions about specific types of information that is shared. So when we changed the exposure from EHR, HIE present to shares radiology reports, we found 17% lower odds of repeat imaging on the same body system for beneficiaries with Alzheimer's disease. And I think this is incredibly important because a major barrier to HIE use among clinicians is that they don't think it has the information that they need to make clinical decisions. However, when we were able to identify readmissions that occurred between hospitals that do share the specific type of information, radiology reports, that could impact the clinical decision we're testing, repeat radiology tests, we did start to see a protective effect of HIE. Similarly, we found that HIE and shared EHR presence was only protective against in-hospital mortality and mortality in the 30 days following discharge in specific situations in our Medicare beneficiary population. It appeared to be most protective for beneficiaries with Alzheimer's disease who were admitted for dehydration, UTI, behavioral issues, or syncope. And again, as I mentioned at the beginning, fragmented readmissions don't impact all patients the same. And it seems like information exchange might not provide the same level of improvement in all situations. And I hope that future research will be able to identify both patients at high risk for poor outcomes in fragmented readmissions, as well as the situations in which information exchange can have the highest impact, which will allow clinicians to use HIEs in the highest yield ways possible. So while care fragmentation has solutions, challenges do remain. A really important limitation that I want to mention here is that for the data I presented, we only know if the hospital participated in HIE or not. We don't know if the physician caring for the patient actually accessed the HIE during the course of care. Like I mentioned, there's previous work that suggests that physicians don't access HIE even when they're available. And a big reason is that they don't think it contains useful information. And HIEs have a huge range of accessibility and user friendliness. So what's going to be so important in the future is getting HIE log data so that HIE presence doesn't have to be the proxy for HIE use. And we can actually see, was the HIE accessed during the course of this patient's care, and begin to get a deeper understanding of how that information can actually impact clinical decision making. And I'm actively working on making this a part of my next grant. So in summary, care fragmentation is common, it's bad for patients, it's bad for the healthcare systems, and it's an equity issue. And HIE might be a systems level solution to the negative effects of care fragmentation. However, there are things that you can do as an individual clinician as well. So when you go back to clinic or the wards this afternoon, I hope that you'll think about how you can ask your patient about fragmented care. Like anything on our differential or in the patient's history, if we don't think about it and if we don't ask about it, we're never going to be able to impact it. So I would love it if you can at least think about how to ask your patients about it, or even start to just ask them. The second thing to think about is, how can you access outside health information? Do you know how to get on Epic's HIE? Do you know how to get on Emory's HIE? Did you know that we have a state HIE called GHIN? If you don't know how to access, figure out who you can ask to help you figure out how to get that information. And finally, what can you do to prevent or mitigate fragmented care? This might be having a conversation with your patients, or as you're discharging a patient, planning ahead if they needed a readmission. And with that, I'll say thank you all so much for attending this talk. And I want to say special thanks to all of my K23 mentors, as well as Ted and Jada. I really appreciate y'all's attention, and I am looking forward to taking questions. Thank you very much.
Thank you so much, Sarah. That was really revealing, I think, for the impacts, and to look at it, the different scenarios, I think really was phenomenal. It really kind of blew the lid off of this issue. One of the questions is, clearly the HIE is a potential solution, as you've outlined. But we are again sitting in a situation where people are overburdened and overworked and so on. How do you see that fitting into workflow? How do you see training physicians to delve into the HIE? What you did with the patient with the sclerotic lesion, for example, is not something that people are going to do on a multiple admission night potentially. And so what are your thoughts there?
Yeah, that's a great question. Thank you so much. So I think that it's not going to be an overnight change, of course. I do think that there is, on the HIE side, increasing understanding that these have to be user-friendly. And I do think that Epic is a really good example of that. And so I think that that'll become more the standard, to not require a separate login, to have the information more integrated with the chart. And then on the other side, on the clinician side, I hope that as my research progresses and others working in this area, as we identify the situations in which having that information might be most impactful, that we'll be able to kind of incorporate that into care plans and workflows, so that okay, my patient who's here for CHF, or had an admission for CHF, and is readmitted for something else, wow, they're really at high risk right now. And I know that accessing this HIE can help me, and will have the information I need. I hope that's another piece of it. And then finally, one sort of trend among HIEs is ADT alerts or push alerts. And I think that that could help this situation. So, it doesn't make sense to go into the HIE for every patient, not knowing if there's even anything there. But if you get an alert saying, hey, your patient was just discharged from Emory 20 days ago, the discharge summary is available to you, that I think could really help in terms of the yield of the time and it would take in accessing the HIE. And I do also just want to acknowledge that I think at least for me, when I did inpatient, the residents would kind of serve as an HIE, right? Because they have access to Emory and Grady, and they can call their friend at the VA to get some additional info. So, I think that that's not necessarily the ideal because it's not really fair to our residents, but I think that we have sort of ad hoc systems in place that have maybe filled in some of these gaps for years.
Yeah, no, certainly the workarounds. Sort of following along on that, a question from the UH resident room. Now that patients have open access to their information and charts, can we leverage the patients to actually bring in their own medical information from hospitals or clinics?
Yes, absolutely. Thanks y'all for that question. It's a great question. I think that, so I really presented sort of HIEs as the major systems level solution, but I think like a patient personal health record is the other side of that coin. And I absolutely think that you should leverage that information and ask your patient, do you have access to a patient portal? Do you have your discharge summary? That has its own set of challenges in terms of patients remembering 20 passwords and things like that, but absolutely, I think that it's very, very useful to leverage that.
I have to say, I'm always super grateful when I'm rounding on someone and they pull open their my chart or whatever and show me the labs from the other hospital. Again, apropos to a recent experience I had, I was actually paged yesterday from a hospital in Augusta about a patient of mine that was there. And when I asked why the patient was there, I was a little bit heartbroken that the resident said, he's afraid that if I tell you, you guys won't accept him back as a patient. So outside of that unusual, I hope unusual circumstance, are there reasons why patients might intentionally fragment their care?
Yeah, definitely. So I think the most common reason, and maybe it came to all of your minds during my talk, is people seeking specialty care. If you have a diagnosis that needs a certain specialist, or you want to go somewhere for your chemo, that would be intentional and potentially very appropriate fragmented care. And I would also put, maybe not as intentional, but if you have a stroke and you get taken to a stroke center that's not your home hospital, that would be appropriate fragmentation. There is a really interesting paper where they look at fragmented readmissions among liver transplant recipients. And they found that patients were actually more likely to go to their home hospital than their transplant hospital for surgical complications. And you can imagine, much to the surgeon's dismay. And so I think that geography and comfort also can play a big role. Wendy, I'm not sure if your patient lives in Augusta, but if that's their closest hospital, if they need it, so no. But I think that geography and comfort are big, big factors as well.
Yeah, no, actually, those are great. That's great. Thinking of my own elderly parents who, are horrified to think about, walking around a hospital this size and want their community hospital. What about outpatient fragmentation, and what are the bad outcomes associated with that?
Yeah, so outpatient fragmentation is such a gnarly problem because there's a lot of it that is needed, right? If you need a specialist, you need a specialist. So a lot of the outcomes that I shared have been looked at through an outpatient lens. So specifically sort of low value care, duplicate testing, cost is a big one. Mortality, I haven't seen as much looked at, but I think that the outpatient care, the duplicate testing, duplicate radiology procedures are sort of the big ones that I've seen.
All right, and do any of our hospital systems have specific workshops that you're aware of on really how to work through the HIE that's available with each of our different systems?
I am not, that's an excellent question and maybe an opportunity for somebody or me. I don't know, I haven't heard of any. I would imagine that with Epic rolling out at Emory, perhaps there'll be something about how to use Epic's HIE, but I'm not sure about currently right now.
All right. Any other questions, please feel free to raise your hand or unmute or put it in the chat.
Great job, Sarah. I had the PDMP actually save me from a care fragmentation problem, and it was a fragmentation between medicine and dentistry, something that we don't necessarily think about, that, you know, all healthcare is not physician-led, and there are certainly other important things that we need to find out from all health providers. So I don't know if you have a thought about that.
Yeah, I agree. And I think that the PDMP is an example of a very effective tool, but it's focused on such a narrow slice of what we do that we, you know, it's just not more broadly applicable to a lot of these challenges. But yeah, I think thinking broadly about fragmentation is so important. Before I started doing this work, I really thought of it very narrowly as kind of something the patient experiences when they're going to different doctors or going to different hospitals, but you can get very micro with it, or you can get very macro with it. The most micro would be, for example, interpersonal fragmentation. So even in a non-fragmented readmission, you're cared for by different people. That can lead to some fragmentation. To macro, if you're, you know, readmitted in a different state than your index admission was. You know, it's one of the things that I love about this area is there's so many different ways to slice it. But looking beyond kind of the medicine / physician centric view, I think is really important for kind of understanding the full impact of fragmentation, but also the full potential impact of solutions.
So speaking of solutions, I think Lauren Collins has a great comment here. Along with increasing HEI access, is availability of providers for direct peer-to-peer discussion part of the conversation? Because we all know that sort of reviewing labs and imaging reports loses some of the story, and our documentation is always not great at talking about the story.
Yeah, that's a really excellent question. I haven't seen sort of peer-to-peer conversation proposed as a potential solution, but I think that that's an awesome idea. I wonder about the challenges in terms of volume and time and things like that, but I love that suggestion.
How about, here's another great comment. In the past, when I've tried to argue, this is Eric Hyman, for universal shared HIE, I've heard people's concerns about the risk of compromised privacy and confidentiality. Any evidence for that or lack of evidence for it? And what do you tell people when they raise that concern?
Yeah, thanks, Erica. That's a really good question. I've heard that as well as a concern. And nobody's brought it up to me personally, more of like a general concern. I haven't seen any evidence for it specifically because, we haven't gotten there yet, but I will say that a goal of the federal government's Office of the National Coordinator on Health Information Technology is a nationwide HIE. So I feel like if they're on board, that's reassuring to me. I think the bigger challenges are things about data interoperability, like matching patients to the right person, which could lead to some confidentiality issues. If I'm matched to another Sara Turbow and I access a record and see somebody else's health information, that's obviously a big problem. So I do think that we have the technology to protect patient confidentiality in universal shared HIE, and that some of these other problems will just require us to work through them. So the short answer is that I think that it's a addressable challenge.
Well, I guess I'm thinking of also, I have young adult or adolescent patients on parent insurance who get their HIV care separate from the linked insurance account, essentially. Awesome. Well, any other questions out there? seeing none, I want to thank you so much for this presentation. This was really fantastic, and I think gave all of us a lot to think about and ways to engage in the future. So Sarah, thank you so much.
Thank you. Thank you so much, everybody. I hope you all have a wonderful afternoon.